the specific kids and cases that we saw, but really to talk about the process. So I put some prompts up on Canvas to kind of get our discussion going. But I think it might be helpful, even though I just said this isn't the point, it might be helpful for maybe the person that did the ISS to give a 2-minute summary of each case, what the big primary questions and concerns were, a brief summary of the results, and then we can kind of get going from there. So I don't know if Abby or James who wanted to start, but if one of you could briefly go through each kid.
Abby's in Hawaii, so I guess it falls to James.
Abby won't be doing that then. I would like to be in Hawaii. So any volunteers? I guess Kate, you were there. I know I'm kind of putting you on the spot, but you participated a lot in that ISS visit. Would you be okay with that?
Yeah, I can do that. If James doesn't mind going first, I can get my notes pulled up before I do that.
Perfect.
Yep.
I mean, is that okay, James?
Yeah, that's fine. All right, so our kiddo was a 4-year-old referred for behavior concerns and possible autism. They have a family history of autism as well. His older sister has a diagnosis. And so when we did all the evaluations, the final diagnoses were the autism diagnosis as well as ADHD, predominantly hyperactive impulsive presentation. And then there were a couple of OT difficulties with fine motor skills that were noted, and then some PT difficulties in terms of gross motor development, a little bit of a delay there. But biology was normal, speech was normal, and all the other evaluations came back normal as well. And so, and he also has average to high average cognitive skills. So that's really great strength to warm. Lindsay, did you want me to talk about the ISS now, or?
I think that could be helpful because I was just thinking nobody knows how it went. So it might be helpful to go through briefly how it went.
Yeah, sure. So I think both parents did not seem to expect, well, I think to some degree they expected the diagnosis, but at the same time, I think it was really hard for them because now they have 2 children with that diagnosis. And I think that they kind of fell into a bit of a trap where they had been told that their daughter was high functioning, and she seems to have a little bit more difficulty with some of the social emotional skills and repetitive behaviors than our patient did. So for them, that was kind of the upper limit of autism. And so when they heard the diagnosis for our patient, I think that kind of took them by surprise because it didn't quite align with their own like benchmarks for what high functioning autism was. Dad took it a lot harder than mom did. I think mom kind of initially was kind of taken aback, but then realized, yes, like this is kind of consistent with what we see at home. It's consistent with his strengths that we had gone over. And so she was focused on what are those kind of next steps that we can take. Whereas I think Dad was just really taken aback by now having 2 children with autism. And then they also received the ADHD diagnosis pretty well. And that again aligned with what they were seeing at home and what they were hearing back from school. And I tried to explain to them how a lot of his strengths maybe played into the fact that teachers are reporting more difficulties at school than they were noticing at home, and really kind of tying that to the ADHD diagnosis. So they were both like really open to pursuing next steps, which is really social skills training for a patient. That was really his one area of weakness. But I was a little surprised by how upset Dad was in my experience giving feedbacks. Usually the fathers are not the ones that kind of break down and start crying and getting really upset, and they're maybe a little bit more like kind of oppositional, I guess, to the diagnosis, or kind of a little bit more defensive, whereas you could tell that it really affected him.
Sorry, I just took a bite of food. But that was a really good summary. Just before we kind of flip to the other kid, does anybody have any questions about how that last visit went? Okay, cool. So Kate, you feel good? Ready to rock?
I think so.
All right.
People can chime in if I forget things. So we had a 4-year-old boy who was referred for concerns with impulsiveness, aggressive behaviors, a lot of non-compliance at home and school, concerns for elopement, and then some speech delays. And cognitively, he was right in the average, maybe a little bit low average range, but no major concerns there. We ended up diagnosing him with ADHD, explaining some of the emotional variability as well as some of the behaviors. And then we noted that he certainly seemed to exhibit some signs of anxiety, but kind of prioritized the ADHD and behavioral things right now, thinking that might target some of the anxiety as well. And then related to speech, he did have both expressive and receptive language concerns, so we recommended speech and language therapy. And he is currently in Head Start, so to continue speech therapy there as well, or whatever school setting he'll be in next. And then related to his motor functioning, he kind of had a lot of things going on in different areas, so including his motor functioning. So OT found that he had just decreased activities of daily living, poor fine motor skills, some sensory processing difficulty, and some behavior concerns that, again, might be more related to the ADHD, might be related to some of the sensory processing. And then with physical therapy, we found that his right foot kind of turns out a little bit, especially when it's tired, so kind of contributing to his walk and some of his balance. So he had some gait abnormalities, some balance difficulties, muscle weakness, and lack of coordination. So our overall recommendations really fell along the behavior and ADHD. We did want them to get into some OT and PT eventually, but really knew that some of the behaviors may get in the way. So recommended targeting that first, and then trying a prescription of, we initially thought clonidine, but the family wasn't comfortable with that. So something kind of in that family where it's not a stimulant, but should be kind of a lower dose for ADHD that might help with some of his behaviors and help with some of his sleep at night too. Let me run through here. We didn't have concerns with hearing, and I think that covers most of that. Just related to his at-home environment, it seems like sometimes there's just some changes or different people with different caregiving strategies caring for him. So we know that that might contribute to some of his behaviors too. So with behavior therapy, just recommended that as much as his caregivers could be involved, that would be really helpful for them. And we had some difficulty. I think mom was able to access some of the information before the ISS, and it was a little bit overwhelming to her. But Shannon talked through that with her and did a really nice job of making mom feel a little bit more comfortable. And then from my perspective, I think the ISS went pretty well and we were able to break things down. I think mom maybe had an initial chance to have her emotional reaction to everything, and then was a little bit more ready to hear us and understand where we were coming from, and why we were recommending the things that we did. So it sounds like they're going to get set up with that prescription and hopefully some behavioral therapy before moving on to some of the other recommendations.
Thank you, Kate. So I think everyone that participated, there's a couple of prompts, and I think, we can start by maybe talking about things that you think went particularly well with each kid, things that you're proud of or were handled really well. I just lost it. There it is.
I think the language piece and how we kind of use written communication was done flawlessly when mom was talking about like reported and those types of things. Like as a team, everybody adapted really well. And even now, like this morning, I had a family like looking right at me when I was doing my notes. And so I kind of remembered ITT and was like, oh gosh, I should be really mindful of what they can see, just how they were sitting in the room. So I think that was a great model for future clinical work. So good job, team.
With Team One, I love the fact that we were able to do the teachers and everybody else virtually for the ISS and try to get as many people involved as possible. And throughout the entire thing. Because I think that was a big struggle with this family and trying to work between mom and everyone else. I'm sorry, guys. I'm just going to be quiet now.
Don't apologize. I love it. Very cute. But that was a really cool and unique situation that we don't usually have in our ISS appointments. We don't usually have school teams available and willing to sign on and participate. So that was really cool.
I didn't get a chance to see James's ISS. I'm sure it was great, and I could try to go back and watch some of that. But in watching Abby and Kate, I just thought that it was really smooth and that they did a great job building rapport and kind of pausing a lot and giving mom an opportunity and asking, if she had any questions or any concerns as they went along, which I thought they just did a great job with that.
I think going off of that, I watched or observed the ISS, and Abby pulled out a diagram of the medications and was really able to walk moms through them and show how they broke up into different groups. And I had no idea that was a thing used, and I thought it was a great visual support for the mom.
Come on, there's more positive things to talk about than that. What else do you think went really well with these cases? I can think of one. Shannon, right? She here? Yes, there you are. Shannon, maybe you can talk a little bit about how you were able to manage that super challenging situation with, I don't remember if it's case 1 or 2, but you were on both.
Yeah, I just talked about it with Marta a lot too, just how a lot of my social work training has come into play and like even past internship experiences. Like last year I was in child welfare. So a lot of the conversations I had were often very difficult. And as a social worker, like practicing cultural humility, I think as any clinician, practicing cultural humility is huge. And recognizing that it can be really invasive to know detail, like personal and intimate details about a family situation, especially in regards to intimate partner violence. And that may not be something that we all have a lot of training on, but even though I think mom was upset, I think just being able to hear, like using a lot of reflective listening and being able to just know that she had our support and that it wasn't just like we were being invasive and like just coming off kind of cold in the way that we were documenting, and just making sure that mom knows, like I made sure to tell mom too that like if there's anything that you feel like wasn't right about the assessment, we can always addend the notes, and that made her feel better. But I think just being supportive and listening and like recognizing that it isn't something that a lot of people want, like a lot of people don't want that information known. And so even though like this whole group of people had access and knew that information, and so just being sensitive to families that experience that, because it is very traumatic for the whole family system, and practicing family-centered care in that way is really important.
I thought on ITT Team 1, we had just a really nice collaborative group or spirit, and that it felt like it was a safe space that people could bring up questions or concerns or things that they had noticed in their sessions that maybe hadn't been documented or noticed in previous sessions, especially with the patient having just very different reactions and behaviors to the different appointments. So I thought that it was nice that we had just such a good team and atmosphere that people felt comfortable sharing different things and working together to figure out what all was going on with that patient.
I was going to say, I think our team 2, did a really nice job of kind of listening to other people's perspectives and really understanding how sessions can differ and look completely different depending on what's going on and what activities are presented and the structure, and how that can really alter the presentation of a kid, but how we need to kind of look at it comprehensively and see what's fitting best. So I think that was good.
Yeah, I definitely think that on team 2, we all saw a different kid in a way. And so like having ITT and being able to actually sit down and talk with every single different discipline was super helpful, and just kind of like a reminder that during our 45-minute or hour-and-a-half session, we only see a glimpse of the kid. And so it's really nice to be able to talk with other professionals and put all of the pieces together.
I was thinking the same thing about our team 2 kid, just how like I never would have like seen him and thought, oh, I should refer him for an autism evaluation. But like trusting James and his psych eval, you're like, oh, wow, we've got so much more information out of this. So yeah, I think like the value of each assessment and provider and like learning where they can really like find things that might not be as obvious to other people was really, really cool to see.
Thank you. So those were all wonderful things, right? And then these kids were both really challenging in different ways. So maybe we can talk a little bit about things that maybe we would have done differently thinking back, or any kind of changes that you may have made in approaching each case.
I know something Abby had mentioned with hers is just how explicitly she was trying to write out the detailed instructions for the ISS for mother, and like more so than what we normally do for our patients in DDBP, because it's one of those where we try to kind of make it very clear and expectations, but with everybody saying like, this mom wants to know this is the next step, this is how you know, and like all the details. I know Abby did a little bit more than normal to try to accommodate that as much as possible for this family and this mom.
I don't know for our case for number 2, after James told us how the final meeting went with, you know, dad being present and mom also being present. I think for most of our evaluations, mom was the only one present. And I think maybe, you know, after we had ours, we kind of had, yeah, it seems like autism. We're gonna do the other evals. Maybe after the second one, that it kind of seems that it's autism too. Pushing a little bit more to see if that could be involved in like a video conference and trying to prepare more, because I think every parent goes through the journey of the diagnosis, and maybe, I don't know if mom was communicating with dad about it, but maybe it would have been less shocking to that if he would have heard a lot of the other providers said a little bit about what we were thinking, because I think in a way, mom was getting prepared for that diagnosis because there were several providers talking about that when she met with them. I don't know.
I know Lindsay and I have already talked about this a bit, but one of the things that I wish maybe I'd done a little bit differently during the ISS was just spend some more time with Dad, introducing him to the process, since it was his first visit, and it is a tough first visit to be at. Like, he's already done all the evaluations, all the reports have been written, all the decisions have been made, and you're only just now finding out like what 3 months culminated in. So that's something I definitely would do differently for this visit, and then also in the future, like for feedbacks, if a parent is there that wasn't there during the initial process, just taking an extra 5 minutes to explain what exactly we did and why we did it.
I already, oh my gosh, I already kind of self-evaluated myself and talked about some of the things I would have done differently in my presentations, but just being cognizant when we're doing these assessments that they are very hard on the kiddos, especially like, 2 to 3, 4 hour long appointments for OT and PT, and just being more cognizant of how I'm setting up my environment, using visual schedules, using behavioral strategies to help promote the best participation for the child. And then also making sure to have enough time to use patient-friendly care and wording when talking with patients and families about the education.
Guys are quiet today. Those were all good learning experiences that you can use and actually integrate real time today, tomorrow. So those are awesome things that you were able to pick up and take away. Are there any other things that you think you may have done differently? Or if you could change, you would change?
I had thought about the ISS visit, and this feels like it happens every year in a different way, but we do things a little differently because it's a LEND patient. And so despite like kind of prepping like the MAs that we're going to use this room, this kind of thing, like somewhere along the chain, it's kind of becomes confusing for the parent trying to check in. And in this case for Cooper, the mom was told he had to be there, and I'm sure that was distressing for her and like kind of confusing, even though he didn't have to be there, but it was only because it was a LEND patient. So I just wondered if like what you guys thought about maybe having a plan, like maybe the family trainee or somebody kind of meets mom the day of the ISS and kind of like accompanies her or dad or whoever the caregiver is to the waiting room to check in maybe, and like just helps ensure that it's smooth. This particularly on that day where it's kind of there's a lot of anticipation, there may be a higher anxiety, and like any kind of like disruption is can be even more upsetting than normal. But it struck me that we had a little snafu with that.
Kind of along those lines, just like having, like, I know we have the ITT schedule, but I feel like when I look at it, I get really overwhelmed because it's all kind of like bunched together, and it has like the evaluation time and then also the time that you're presenting, and I just get overwhelmed looking at it. So maybe just having like an explicit schedule that the family can follow, but also that we as clinicians can follow. Because like I know Risha was supposed to meet with our family right after our speech evaluation, and I had no idea because I didn't see an Epic, and I just didn't catch it on the schedule that was on Canvas. So I thought the family was okay to leave after ours when Risha was sitting in the waiting room waiting for them. So I feel like just in general, having a more explicit schedule could be really helpful.
The other thing that came into my mind is, I don't know if Risha was the family advocate in our case. So did she meet? I think she only met with mom. So if we know there is a couple involved, trying to push for that family advocate to be mom and dad present to see what each side had to say, and how, maybe in the future. I know Risha prepared us and she was like, yeah, I think mom is saying this and that, and I think she was on point. And it's just so helpful to see the perspective of a family that sometimes as providers we're not able to. But if we know there is a mom and a dad, or a mom and a mom, or a dad and a dad, or whoever the support person is, maybe trying to have that family advocate also meeting with them, so then we don't have surprises in our last meeting.
I'm going to share something. I'm not a clinician, and so if what I share sucks, just tell me that, because you may say, Pat, that sounds clear to you. You're not even you're not clinical. But when I was observing, I think it was the PT for Team 2. Throughout the conversation, mom kept expressing what I observed was internalizing why her son was the way he was. And she kept saying something about, is it because I'm a bad parent? My parenting skills, other people have told me that. And she said, I guess it was her husband or the father had said, where did we go wrong? And so it made me think about how many parents who, when they have children that they later learn have disabilities, that their acceptance of it is deeply influenced by their internalizing and blame. And so I was just wondering, is there any part of the process that meets separately with the parents to assess where they are, help to alleviate or dispel some of their myths that they have, that this is all their fault, or even if it was, like, and I won't say it was, but for like a parent who maybe took drugs and, throughout, before she got pregnant and during the pregnancy, but actually to help them process that before the diagnosis is discussed, because I think it's greatly how they receive it then and in the future is going to be greatly impacted by how they personally feel the blame. So I don't know, and you all may say, yeah, we do that, but I just thought that was because many parents of children born with disability somehow in the recess of their hearts feel that somehow they're to blame for it. So I just didn't know if that approach was ever taken, and I apologize if that's not realistic as clinicians.
Hey,
I
Pat.
can say,
Go for it,
Go ahead.
Amber.
okay, I just wanted to say really quick that at least for any patient who would come see a genetic counselor, if we're giving a diagnosis, like we found that your kid has a particular genetic condition, that is 100% a part of our discussion. We always talk about like parent guilt, and like we are, even if the parent doesn't mention that like they feel like it's their fault, we do always make sure to say like, this is nothing you did. There's nothing you did to cause this, which we can say for sure with genetics, because it's not something the parent did or didn't do for sure. But that is something we always talk about, and something that parents seem to find very valuable when it is brought up to them. Go ahead, Kim.
I was just going to say, Pat, I don't remember that exact part of the evaluation, but I know personally I try to address it in the moment and try to explain if I maybe didn't do that in the best sorts or something. I'll definitely work on it, but I know a lot of my kiddos who come in with torticollis, that's where they have tightness of the neck where their head kind of tilts one way. A lot of moms come in and they're like, what did I do wrong? Did I not put them on their belly enough? And whether or not, usually if, for instance, with torticollis, it kind of just sometimes happens, sometimes just because of how they sleep on their back. And we try to talk through with families that typically it is not their fault. It just kind of happens. And then I usually try to switch to more of an empowerment thing, like trying to give the control back to them. Like, this is what you can do now. We don't maybe necessarily know what caused it, and how we can kind of go forward with it. But I think that's such an important perspective, because I feel like a lot of moms and dads may have guilt or have like what ifs, like what if I would have done this, or what if I would have done X, Y, or Z. And I think Amber brings up a good point that often, like with genetics, it's really important to talk to them about that kind of stuff too, because that's kind of a touchy topic where they gave the genes to the child, but it's not their fault. But I think it's such a good point that you bring up, Pat.
Yeah, and I come from a very social, cultural perspective. And so sometimes it's so deeply rooted in something that's not even connected with the child, that it's easy to miss the fact that what they're expressing is really not solely about the diagnosis. There's some other things in the diagnosis that's caused it to surface. And so I was just wondering if there's ever a connection for therapy for the parents, that's like over a period of time and at their discretion, and if they want it, so that I'm just bringing up, again, because I'm coming totally from a social cultural perspective. So I just thought you know, because sometimes, like I said, it's not rooted really in the child. It's some other things that have happened in their lives. This is causing it to come up to the surface. So it's just a thought.
I know this is something I struggled with too with families, even as a general pediatrician before becoming a fellow, because it's one of those where we try to support parents as much as we can, and exactly what you said, but a lot of times we don't have resources and we don't have abilities to even put forward to parents. And I'm sure Andrea can have the same thing at times where you're like, as much as we're limited in child psych and child treatments, even more so sometimes with parents, and they're so focused on their kid, and it's a, hey, you know, you need to think about yourself, you need to do more for yourself. But even as a provider, I was like, hey, this mom's showing really high for a depression rating scale, and what can I do? I can give her a handout and say, go talk to her provider. So it's been something that I've been frustrated with in many ways, even before now. So I love all of your perspectives.
So I'll go ahead, James.
I was going to say, I think from a psychology perspective, it depends on what specific behaviors there are. So there are certain behaviors that you can kind of tie to or associate with differences in brain functioning or things like that. So, you know, like attention or executive functioning or some of those autism behaviors. But then there are other behaviors that really are kind of closely related to parenting behaviors. So things like non-compliance, right? That's something that, you know, there's not necessarily a sort of biological or developmental foundation to non-compliance, and it often is related to how the parent and the child interact and what behaviors both of them have found to be effective or ineffective at communicating. And so that is something that we can address with, you know, parent training and behavioral management strategies. And I've had this come up before in my other placements where the child is not receiving a diagnosis of a neurodevelopmental disorder like ADHD or autism. It really is, you know, a pattern in the history of ineffective parenting strategies that can be changed with the proper tools. And not every parent is going to know those tools. And so we try to frame it that way when we have feedback with those parents, where we're not saying that is because of how they have parented their child that their child has these behavioral difficulties, because you don't want to blame the parent, but it's more so framing it as like, as a parent, your first instincts are usually right, but for some children, it's not effective, and it's not the way that they're going to respond and act the way that you would like them to act. So now let's try these different strategies that we know can work. So, but it can be tricky because you don't want to blame the parents, but at the same time, like, you know, it is coming from that behavioral perspective and the interaction rather than some other condition that is more easily to deflect blame or responsibility towards, like the way that their brain has developed.
Marta, were you going to say something?
I was typing it and it's getting long, like Steph said. Most of the kids who get a new autism diagnosis, at least in the division, are specified autism, spina bifida, Down syndrome diagnoses. We follow up with families. So most of the time the provider who gives the diagnosis sends the chart to us in social work, and we sit on it for a little bit. We give the family a couple weeks to process it, and then we call. And when we call the families, we say, we're here to, you know, we're calling to check in on how things are going with your child. We're also calling to see how you're doing. How are you feeling like you want to talk about this? Do you want to talk to someone else? Do you want to talk to another family? And then we connect them with family supports or support groups. And then we start a conversation there around, like, how are you handling it? And do you need to connect to mental health services? And if so, how can I help you do that? Kind of just depending on where the families are. A lot of times, even at that first one, they're like, I'm not ready for that, but, you know, give me your support group information. And then we get, like, last week I had a mom coming back. She's like, you know what? I think I do need therapy. I think I need to talk to someone who's not going to judge me and who's going to get it. And so I was sending her support, some community options, community providers for mom to connect to, to have someone to talk to too. And I do have families, moms who've been really open about blaming themselves. And so we've had some really open conversation. And then those moms, I've always offered mental health services to them too. But not every parent is ready to or cognitively aware of the blame or understands what that feeling is. But over time, sometimes we get there, and then we do help them connect to services for the parent also.
I'm just going to put it out there as a parent perspective. Yes, I blame myself. When Maddie was first diagnosed at the age of 3, it's just your common thing. You're trying to figure out why. With Maddie, there's not a reason why. We did genetic testing. We've done MRIs. We did EEGs. You name it, we did it. We did the craniotomy. And we still don't know why. So again, you think, what did I do during pregnancy? I didn't do anything. I didn't smoke. I didn't drink. I didn't go out and party. Didn't do any of that. She was born on time. She was a week late. I'm going to be getting emotional about it. It's been 22 years ago. But I think every parent goes through that, whether they say it to you or not. In a way, they are possibly thinking that. So with me, I started reaching out to the Epilepsy Foundation, getting support from other parents. There's a Northern Kentucky group of parents with disabilities, of children with disabilities. They get together once a month for dinner. So we all are supporting each other, but we're all different kids and adults with disabilities. It's not just epilepsy. That's kind of like this. We're all looking at different disabilities and how each parent tries something different. And it's like, oh, you tried that. I tried this and it worked. Try it with your kid. Maddie has a best friend whose daughter has Dravet. She started having seizures at 3 months. I couldn't even imagine that. But we've kept in touch. They moved to Louisville. We kept in touch. And it's just that little bit of support just to think that I think every parent, especially moms, like I tell Amanda, your mama bear is going to come out. Now she understands what mama bear means. But with me, I never said it to a clinician, but I would come home and talk to my husband about it because he had some of the same feeling because what if I did something? So we both kind of worked together. But like our ITT team 1, I think the hardest part for me was mom kind of understanding there's something going on. And you want the mom and the dad to both come to the meeting. But mom had said, dad says boys will be boys. So they're not on the same page. So how do you get that family to come into that ISS and explain it to both of them so they can both understand? Because I don't know. I've talked to mom and I don't know. I know she kept saying, yes, she understood. No, I don't have questions. But it was so much information. I don't know if she could have gone home and told dad 100% everything correct, if that makes sense, without trying to blame herself or whatever. I don't know if that makes sense.
2 points. You made added a lot of great information, Donna. Thank you so much. Just like that richness of that personal, like lived experience, I think is so helpful. But also for everyone to keep in mind, I have 2 of my 3 children with neurodevelopmental diagnoses. 2 of them are adopted. And I also have significant amount of guilt and thought of what did I do wrong? And so, remember when you're talking to families, even though there isn't possibly a biological connection, there still can be these feelings of what did I do wrong? How did I not parent? Did I not understand adoption? Did I not understand biology? What did I not understand or what did I miss? I think parents can also have feelings of guilt, or they're processing through as diagnoses possibly change over time as we learn more about a child, or we see something and we realize we need to go a different direction. Sometimes as a parent, although it's a light bulb clicks on, you're like, oh, finally, I think we're in the right place. but you still, I think I see parents still looking backwards and thinking, how did I miss this earlier? How did we get to this point without the accurate diagnosis? What did I miss? Or what did I not share accurately? So I think there are just, there are a lot of complicated feelings tied up in each individual parent or caregiver. And then when you add that there's a dyad or a triad, if we've got a grandparent that's a support person, each one of those individuals has really complicated feelings about the diagnosis, about what disability means, about what it looks like, and whose fault it is. And I would agree with both of my moms. We had some interesting discussions, I think, with although they were moms coming in and talking with us this semester, there were some dynamics of, was this my fault? Was this the father's fault? Whose fault was this? So even when you have everybody there, there's some dynamics that are not being spoken, but are going to play out in the car ride home or later on when one parent is going to share information maybe with another parent or caregiver, and then how that's perceived. So it's really complicated.
Yeah, Molly, and I'm so sorry, but I just love the cultural piece of stuff. But there's one more component side of that a lot of people don't think of, and that is that regardless of whether there is a connection, spirituality, however that is defined, a lot of times is viewed as punishment. And even if the person does not have a specific religion or denomination they're connected with, they may have grown up in that environment where the generations before basically sent the message that when things like this happen, it is a way of the higher being, however you define that, whether it is as Muhammad, as God, it's a form of punishment. And so sometimes they don't even realize what that connectedness is, but culture and social environment impacts people so greatly and beyond what we can fathom. So that is another thing to keep in mind too, is sometimes people view it as a sense of punishment for something that they previously did.
Oh my gosh, Pat, you hit it right on the head. When I first got Gracie's diagnosis, at first I felt like I didn't eat enough folic acid. And then I felt like, okay, God has punished me. What did I do wrong? So I think that parent guilt is there a lot of, it doesn't just go away after you get the diagnosis. It doesn't. And I know that social work calls a couple weeks after you get the diagnosis, but as a new mom, when I first got that diagnosis, I wouldn't feel comfortable telling you I needed mental health. I needed to talk to somebody, because you think of social work and you're like, oh my gosh, if I say I have any weakness, you're going to try to take my kid, So I would also make sure I advocate for the support groups and everything, because like with me and my parent guilt, it's not like it was when she first got her diagnosis, but you still go through your stages and everything where you talk to other parents. Like Donna has been wonderful for me since I've met her, there's all the stuff that Gracie's been going through. She's been right there checking on me, but I think as parents, we have to stick together. And I think in the ITT cases, it would be helpful when we have the information sessions, if you have family in the room, because our information session last year, I wanted to be in there with the parents because I just seen the mom crying and I wanted to tell her like, you did nothing wrong, but we weren't there. But I think that will really, really help the parents if they want that.
So I would like to, I think there's a lot that goes into this, and I think it's a lot on a lot of different things that we put this on. But I mean, this has a history of, like what Pat said, there is a lot of things that went in with religious affiliation or even dharma or karma of that you did this, that would say that disability is something that was put on something as a curse or a way to do that. I mean, you look at even folk at like changelings in history that would become things where that would we would later call Down syndrome, were put into somebody as somebody who thought that their child was stolen from them as things, because I've researched some of this history. We also see that is some of the ways that some of the sciences that every one of us is doing is based off of some of this, and that there's calico families or bad genes or bad parenting styles that would go into putting women or people of color into institutionalization based on these ideas that they didn't fit into the social norm and that they needed to be put into certain places. And we have to be careful too as we do this, as some of these sciences, while there's behaviors and stuff that people need to improve on, they also don't always meet what the person themselves or the families want, that can cause strife between the two. I mean, it had a lot of strife within my family and can cause the family to feel bad, can cause the person to necessarily feel bad in some ways, and making sure that we're not saying the sciences themselves are perfect either, are always 100% person-centered, because I think there's a lot of feelings of, oh, well, they must know this and they know this 100%, and so it can't be them, and then that can create resentment with the systems later, whether it's from a person with disabilities perspective or from a family perspective, and can sometimes have conflicts between those both, because we're sometimes telling that this is the perfect intervention or this is the perfect thing, or you just do these things. But some of the things that my parents were told actually made behaviors worse in some ways, because I felt ignored, or I felt like I was a bad person, and they felt like they just wanted me to get to do things, and they didn't understand the way my brain worked, that the way that they were telling me or the ways that we were taught of it was basically telling me just not to do anything and then not talk at all. And then as I wanted to get more older and get my own independence, it caused a lot of butting of heads, and so we had to have intermediaries between that too, because not that either one of us didn't like each other, but we had different ideas of what we thought were going on. Sorry, I know that was not coherent at all.
That is all super, very relevant and important feedback. And I think all of us can integrate all of these things that we're learning from each other into our clinical practice and moving forward. And really, we really value that family perspective. So thank you, all of you, for sharing that. Maybe we can kind of shift gears and talk a little bit more about the multidisciplinary approach that we were able to take in this unique ITT situation that is not going to, most likely not going to be your regular clinical practice. So maybe we can take some time to kind of go through and talk about some of the things we were able to learn from each other, either by observing other disciplines or in your case conferences with your other disciplines.
I really like that topic, and I will say I agree with you completely. It's definitely not realistic that this can happen for everyone that we see in clinic. However, having this opportunity, I think, really helped me learn more about what each discipline does, so that way I can pinpoint things that I see in patients, and I know exactly who to go to, and I know what things to look for, and the different reports that I read and things like that. So I definitely learned a lot about different disciplines, and I definitely feel like I am more likely to reach out to other disciplines for advice or information, or just to ask questions about, does a referral to you make sense, and kind of talk things through.
I was want to share. So with Team 2, I want to be honestly, I struggled with the diagnosis on a personal level, and I found it very, very interesting. And I appreciated all the clarity that all of them were able to provide to me, because I've never been on that lens of that medical side. But it also, I think, connected, because if you don't go to the right person, they might have a completely different view, and it might be completely missed. I mean, we really did have a diverse spectrum of what people saw within that child. And so even experiencing that with my daughter, you don't know if you're even getting the right information. And most of the time it's the parent trying to decide where to go. You guys, I mean, not all practitioners are involved, and they'll just let you lead. Well, what do you think might be going on? Who do you think you might need to see? And so knowing that that scene can be seen differently was very, very interesting to me.
I think going off of that from team one, kind of learning how important terminology is and the word trauma or mother reported, just being really mindful of, yes, it's important to educate the family and understand things, but you also don't want to lose the family. And we need to build that rapport and understanding, balancing the diagnosis and the words. And I think I learned a lot. And I asked the group, like, Kim and I talked back and forth, like what's right, what's important. And I'm just really grateful for social work and truly understanding what social work does. And I've learned so much from the team. And now I feel confident reaching out to them when I have questions with those more difficult situations.
Yeah, I agree with everything that everyone's saying. But also, like, from an accessibility standpoint, I love just the fact that these families can participate in these multidisciplinary sessions and kind of have like a one-stop shop of they come here and they see all of us. That is not through insurance. It's technically free to them, and they really get all of these problems ironed out, and they kind of have some clarity in that respect. So I was also just curious, like from a scheduling standpoint, I don't know how you guys schedule these appointments, but like I know that for team one, our patients were traveling 2 hours to get here from Kentucky. And so I know that OT and PT have combined time blocks, but I was wondering if like speech and psych could somehow be combined in sort of like an arena setup, or just making it like just slightly easier, or if the parent or if the family has the option to combine them if they want that. I just feel like that'll even make it more accessible to them if it's possible.
Scheduling is a beast. I'll just say that. I think that's a really good point. Definitely more feasible for the younger kids, probably not feasible for the older kids. It's something we could definitely consider, but getting everybody's schedule synced up is the hardest part. Marta looks shocked, and I'm hoping it's just about her microphone. Okay.
So as a provider who's had the privilege of working at Children's Hospital for over 20 years and being able to work with teams that entire time, I can support to you guys as new providers that you're still going to feel awkward, but when you reach out to the next provider and have questions, they want your information. They want your support. They are looking for it. That is going to be, people like to work in teams as a generality. They may not know how to, but don't hesitate to ask questions of the next provider. You've had this great opportunity. You've had the opportunity to work with people over 2 semesters worth of time. And so you feel comfortable with this team, but I can assure you that people reach out to me from Dayton Children's Hospital. I've never met them. I don't know them. They want help. And so you're going to get that from providers that you've never seen before. And you should feel the same, that when you have questions, other people can support you on this. And it's always about the benefit of your patient. So this kind of interdisciplinary care, it's not going to happen in this really magnificent way that is Len training team. That is unlikely. But you can make that more a part of your daily practice by working with people and reaching out to people when you have questions or when you see that there's a difference. So I just encourage you. I know that you're really safe in this environment because you've met these people over a long period of time. But most often other providers are collaborative and they want what's best for that child too. And so they will seek your input and your questions.
Don't forget to extend that to the teachers in the school as well. So like we saw with Shannon in social work, so many times that's part of what they do, but I've really become familiar with some of my more complex patients where families and teachers are giving me completely different answers for how's medication going, how are things going. And yes, you can send Vanderbilt, you can send forms, you can do stuff, but actually getting to speak with those educators and providers. So I think a lot of times with this, we think about like our own colleagues and like this within Len, but just remembering that no matter what you do it's always helpful to reach out to that school potentially as well, and any other outside specialists that they're seeing.
Nicoletta, I actually said that to Jen and Steph this morning, that I feel like the teachers really like have a place at the table here, because a lot of times teachers get to see these kids for longer parts of the day than their parents. And they also get to see them in a setting where they're asked to sit still in a social setting. Like sometimes it's very structured, sometimes it's unstructured. And they really like just want the best for the kids. Not that the parents don't, but the parents also sometimes don't want certain diagnosis. So they might steer their answers to like maybe not push you in a certain direction, where I feel like the teacher should give you just like an unbiased opinion on what's going on.
I would say that, I mean, I'm not saying that, I mean, I think teachers are great and it's important to get different perspectives. I think everybody's biased in some ways, even the person themselves is biased. I mean, I think we cannot be that there's no bias in these situations from anybody. It's important to recognize our biases or where our positionality is coming from, and that different people have different insights because they're seeing people in a different situation. Sorry, not to be, I mean, even I have bias towards my own self in some ways, or positionalities that I hold. Sorry, not to be rude or anything.
No, you're fine. And I mean more like just thinking of, you know, like my own kids. Like I like to think my kids are friendly and outgoing and make friends easily, but that's like in in settings they're very comfortable in. But like a school setting, you have to like make friends with people maybe you don't get along with all the time. So it's just, you're just getting a different opinion is maybe a better word.
This is when it's hard not to bring in my doctor perspective though, because I know I talked to Julie about this before too, but with my son being a younger 4, he will be turning 5 right as he's starting kindergarten. I'm waiting for the teacher to be like, he has ADHD, you need to treat him. And so I'm also waiting for that perspective too, where it's like, well, you know, how much of this is because he's still age appropriate and you're trying to compare him to the kids that are a year older than him, yet they're still within that grade level. So I go both ways too with there. And I know it's, again, like Jason was saying, my own personal bias and knowledge that I bring into it that.
But you could also say that it could be both ways, because the teacher might have it easier in some ways if there's something with that in some ways. And not saying that either is wrong or right, but each person has their own perspective on what does and goes into their own resources. Because as much as we want to work on teams, and we do, we also want to make sure that we're having some position to be in somewhere and that our perspectives are being held. And that's okay, that's human. Sorry, not to be like direct. Sorry.
Yeah, I would like to add that, you know, I love multidisciplinary approaches. I love it. And when it is done in adult medicine, it works extremely well. Like some of the cancer institutes have started to do that. The only thing I would like to suggest is making sure that the multidisciplinary is also multicultural, because that brings a piece. For instance, like if I'm a part of the team, I know the Black family dynamics, and what may be viewed by one is, did you see that? You know, I may say, you know, oh yeah, that doesn't mean anything. So I think it's important to be multidisciplinary, but then also multicultural, and also not just from a race or ethnicity perspective, but age and all of that, because it can be, there's more and more grandparents now that are raising the grandchildren who have disabilities. So I just think that would be my only suggestion. And then last of all of you who work in peds, I bow down to you, and there is a place in heaven for you, because I was going crazy watching this. I'm adult medicine kind of girl. And I was like, oh my God, there's a palace in heaven for them for doing this. So I thank you all for doing it, because you all were phenomenal. I don't know how you did it. Like I said, I was pulling my hair out watching. I was doing it for you. So, that would be the only recommendation or thought I would have, is that when it's multidisciplinary, make sure it's also multicultural.
I just want to say to my group that I work with ITT, you guys took the family perspective. Abby and Kate on this last one, when I said mom wanted written stuff so she could write stuff down, you guys broke it down step by step, which was awesome. The other thing I just want to suggest is like with Maddie, when she was younger, I could talk in front of the doctors about anything because Maddie didn't understand it. As she got older, I didn't want to talk about Maddie in front of a psychologist or in front of her neurologist about what was going on. So I had that rapport with both of them while I was at Children's, that they would send me a questionnaire or an email like a week before my appointment, said, hey, what's going on? How is she, just something. So when I took her to psychology, I didn't have to sit right in front of her and talk about her because she wouldn't wait in the waiting room. She loved the psychologist, which was awesome. But I didn't want to go in there and say, you need to talk about this, 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 and this. But if I could send her some little tidbits, she brought it up to Maddie, especially as she got older, because she did start catching on to stuff. I didn't think she ever would, but she did. So yeah, just little things like that. So I did have that rapport with the neurology department and with psychology at Children's, which worked great at that point, because then it was her talking and not always me.
Christy, you kind of already alluded to this a little bit when we were talking about what we learned from different disciplines, but I guess our next prompt is really, what do you think would be different had we not had this amazing opportunity to do this really thorough multidisciplinary evaluation? How might the outcome be different? The recommendations be different?
I feel like one
experience was the last one. How might
I was just going to mention that I feel like with both of these cases, unlike kind of the fall, we all kind of saw different versions of the child and how they presented over time, and depending on what demands were placed on them, how they responded. And I think if we hadn't all kind of been able to see that and really taken the time to read each other's reports and findings, we probably wouldn't have seen that whole picture of the child and the family. We kind of I maybe would have just gone in with just the PT aspect, or like just kind of with my blindfolds on, where I feel like with interdisciplinary team meetings and actually having that dedicated time for kiddos, you kind of get that whole person perspective more so than just the specialty perspective.
I completely agree with you, Kim. And touching on Christy's message earlier, seeing the Team 2 kiddo in audiology for an hour, the behavior concerns, the impulsivity, things like that, they were noted to some extent, but I was shocked by everyone else's interpretation of his behavior. At the end of the day, I was like, oh, wow, that's how he presented to you. Because I wouldn't have, I'm not sure that I would have referred for further like DBP evaluation based on our just 40 minutes together. So seeing all of those different reports and noting how different the child can be from one appointment to the next, one day to the next, I think is a huge benefit of ITT and the interdisciplinary approach to all care for all of our patients.
I think going off of that with Team 1, I feel like if we didn't have this open communication and such a strong team to support the family, we really could have lost Team 1 and they wouldn't have come back. And I know when I do an OT evaluation, I don't follow up and see if they scheduled OT. They're on my schedule for one day and I evaluate and then that's it. So I really feel like we did such a great service to that family and supported them. If they weren't connected with social work, who knows where they might be. So I think the team aspect was just crucial with that case specifically.
I think it's helpful too, and I think we saw this just a little bit, that you can prioritize. Like I know that PT and OT maybe is not highest on the priority at this point. And if everything is happening separated, PT and OT maybe doesn't know what else is going on, and they are saying, yeah, you got to get them into therapy, this many times a week, without knowing that there's other things going on, and those maybe are higher priority at this point in time.
Angel, I feel like I'm living that experience. I like literally like neurology, psychology, I mean, therapies, regular physician, and then I keep getting more and more specialties that are brought up, and neuro testing. And I mean, I'm so overwhelmed this past year with how many times that we've had appointments and how many times I've had to repeat myself, and how I don't feel like currently there's any communication between, because I have to keep redoing psychology. I mean, so many times. And I don't quite understand why we have to keep redoing it, but I think that's a very, very good point that, yeah, we're doing multiples because everyone is giving us advice separately.
I think you want to remember too. I mean, I've only been on this from the patient side and seen some of it and then looking. I mean, it's a lot on the person too who's getting it. And if you've done this multiple times, you kind of know what you're doing, or, oh, it's another person who's coming in, or it's another test, or it's another thing that I'm being asked to do that I don't necessarily like. I mean, I think there's points too where, depending on age and stuff, and especially with the first semester people, that, you know, oh, well, I know that they're judging me, or they're looking for something that I'm not good at, or if I'm not answering right or something, or not doing it right.
And then thinking of all this in regards to the transition care, because we've been talking about that a lot in the last couple of weeks. And if you have all of this and you're trying to give your child their independence and get them to gain, and you have exactly what Jason and Christy and everyone's been talking about, it's like, how are you supposed to continue to push them and encourage them to become an adult, to become independent, to take care of all this, when it's like, why am I doing this again? What are we doing again? So from the child's perspective of gaining that independence and transition.
Well, essentially, I mean, I think there's sometimes where we see, because we ask this, and I think this is one of the things, why is there such a big amount of mental health issues for people with IDD sometimes? And I think some of it might be neuro. I mean, I don't know how much of it is neurobiology, but also being told that there's something wrong with you, or that you should always be listening. I mean, it seems to be that there's always some point of it when you're not supposed to, when you're teaching not to accept who you are in some ways. And that doesn't mean that there's not ways that you're accountable to other people, that your behavior, but when you're being told that you're always supposed to, or that people are just coming into your life and they can just touch you or do certain things as well, or that you're always supposed to, somebody always knows better than you do, even about your own self, and being, well, those emotions aren't real, or you're not taught to really deal with who you are in some ways, or how to regulate it. I mean, I know there's other things, and there are in some ways, but it can feel like that.
Well, I know I hope I didn't sound too doom and gloom saying you'll never have an experience like this again, because you can. You know, the point is you just really have to work hard at it and make a conscious effort to connect with each other. Like Susan said, most people in this field want to do right by who they're seeing. And so making that effort to reach out to who you need to consult with. I still talk with my LEN trainees from however many years ago that was, if I have questions. So you have each other forever. But it's just something you're going to have to make a big effort to do. Those are all my prompts. So anything else that you think would be beneficial to talk? I was going to ask Marta if she's heard from either of the families yet, but her whole computer just like blew up on her. So Shannon, I don't know if you've worked with Marta to talk to any of the families to get any follow-up information.
Yes, I have reached out to both of the families, but haven't heard back yet. So I'm waiting to hear, but I've also let them know that today's like my last day in clinic. So everything else Marta will be taken care of. So they have her contact information and everything.
Awesome. Well, thank you.
I can share that. Oh, sorry, Lindsay.
Oh, no, go ahead. You know more than I do. I was just heard from Abby.
Oh, you just heard from Abby?
I just knew Team One started medication. That was my
Yes,
thing.
that's
Okay.
all I was gonna say, that we started medication and actually the first one did, there were some issues, so we've switched to a different medication. And then I haven't heard anything back from Abby asked if she's heard about how that one's going, but should find out soon when she gets back.
Well, you all did a really nice job with 2 different cases, different challenges, and they were both really interesting. And you guys did an amazing job working together to come up with great plans for both families moving forward and manage different challenges along the way. I learned a lot from the last hour and 20 minutes from all the information you guys shared. So thank you. Is there anything else anyone wants to add?
I'm curious if there's ways to make it so it's also accessible for non-clinical people. I mean, I know that we do something sometimes and you have family and stuff, but I do think it's one of those things to where I don't know a lot of the chart systems or stuff that's going on that everybody else is seeing. It sort of feels like, unless, you're more listening and sometimes you have something that can be helpful or you're learning a little bit, which is interesting about clinical, but it doesn't really, I don't know, it doesn't feel like there's a lot that I can contribute, that you contribute sometimes or something. And I know this starts as a clinically based thing and that's important, but, I think there's some, just in with Everland, hearing from Everland programs about how some of it does, because I don't mean to sound critical because it's amazing in some ways, but I don't think that, in some ways that it has the same impact. And I think there's, there's a few things, and I love the way that we do Lend in a lot of ways, but as a non-clinical person, I think there's a few areas and that would be interesting to see if there's other ways to adapt it in some ways to make it to where people who are non-clinical still have a stake in it in some ways. Sorry, I don't mean to,
That's a good point.
No. Yeah, and Jason, thank you so much. This is Jen. Thank you so much for saying that. And it's something that we are constantly trying to figure out how to incorporate non-clinical folks. And so I know that all of us who are involved in ITT would really like to talk with you more about that and to hear if you have ideas and if you've talked to other Lend programs that are able to incorporate folks a little bit more. That's our goal. And I think we get a little bit better every year at how to do it, but we have a lot more to do.
Yeah, I just wanted to, I agree with you, Jason. I have just happened to have a, so I understood part of it. I don't have a background in PT, OT, psych and all that. But I agree with you. I felt that basically ditto of what you were saying. So I agree.
I also want to reiterate too, Jason, that I think it's probably hard for all of the other trainees to actually put into words what they learned from you and from the family folks. And so I think it was maybe an experience where you were able to give a lot more than maybe you were able to receive. So we want both of those things, but I hope that you all, especially the family folks and Jason, just how much everybody contributed to everybody else's learning.
All right. Well, I got nothing else, guys. So hopefully you enjoyed.
Is anybody going to object with ending 40 minutes early?
Good. I hope you enjoyed the whole experience. If anything pops up or if you have any more feedback, let Marta and Sally and I know. And then hopefully, Jen, you'll include me in these discussions with Jason, because I would love to hear how we can kind of adapt and move some of those things forward. You did it.
Yay!
All right, enjoy the rest of your day, okay?
Everyone.
Great job, everybody. Thank you.
See ya.